Okay, little discussion on intermittent versus static. Now, I have to forewarn you, there's not a lot going on with this presentation. It's very verbal, and actually, I didn't even put a bunch of pictures in. Just kind of wanted to make this pretty simple, mostly as a screen capture. So first is to really go over and look at the components of treatment really quick. Looking at the vertical axis here, that's going to be the intensity, the amount of force that you're going to be pulling with, and then on the horizontal axis here is going to be the duration, the length of time. So what you see here is there's a progression. So we start with 0 distraction force, we add distraction force until we reach our treatment level, and then if it's sustained, that's basically what static is. And then we have a regression phase where we let the patient back down to where we get to 0 intensity. We also have options of using the stepwise approach, and I've talked about that in other presentations. But this is a look at intermittent, to where we have an intensity that's higher, and then it drops to an intensity that's lower. It goes back up to the higher intensity, and it repeats that cycle. And then we have this regression phase where we go back to. So essentially, we've got really 3 different types. Technically, there's probably more than that, but if we look at the 3 main types, we have static, intermittent, and cycle or cycling. So static is sustained. So that was the first picture slide that we looked at, where the progression, we reach the intensity, the desired intensity, and then we just keep it there. So there's no change in the intensity for the duration of the treatment. So if you're going to treat for 10, 15, 20 minutes, whatever the case may be, and it's set at, I don't know, 50 pounds or 25 kilograms, whatever you're using, it is retained at that particular intensity for the duration of the treatment. Versus intermittent, we saw it's a cycle. So there's usually 2 different, sometimes more, but basically 2 different levels of intensity. So as we go through the progressive phases, we reach our what's referred to as the therapeutic level. We hold that for a period of time, and then we reduce the intensity down to another sustained level. So we may hold those different levels for different periods of time. It could be 60 seconds, could be 30 seconds, whatever you decide. It could be 1 second, so you can actually make it very, very, very short duration. Typically, the lower level, also sometimes referred to as a rest phase, but if you don't go all the way back down to 0 intensity, then it can still be therapeutic. So think about, if you're doing manual therapy, just not providing as much force and allowing the tissue to sort of regress, and so there's a drop in the resistance and decreases the tension on the tissue. And then we have cycling. So this type is, it's a form of intermittent, except there may be no repeat in the level of intensity. So it may go through a complete progressive increase in the intensity. So it may go from 0 to 5 to 10 to 15 to 20 to 25 pounds, all the way until it reaches a peak. And then it may actually go back down, or you may start at a higher intensity and it reduces, say, from 50 to 45 to 40 to 35 to 30, and so on, at a desired duration. So you may hold that for 10 seconds, 5 seconds, 20 seconds, whatever the case may be. So there are some indications, and if we look at the historical perspective, from Cyriax and Saunders and Rogoff and Hood, and there's a few different interpretations in review papers of those findings, and I think that we're all somewhat similar on the same page with regards to why. But essentially, if we try and decipher the distraction pull intensities and the durations, it sort of brings us back to manual therapy and why we have these different phases. And so basically, with today's devices, we have an opportunity to sort of mimic some of these manual therapy protocols it is in a distraction, or in the case of spinal, it's axial distraction, that we can correspond to mobilization grading, such as Maitland and Cyriax and Kaltenborn's. And so we kind of use the same interpretation as to why we would use different pattern, whether it be static or different types of hold patterns, whether it's intermittent or cycling. So when we look at not only the duration of the hold patterns, but you would also have to take into consideration how quickly you want to transition from one level to the next, as well as the overall amount of intensities. So in a moment here, I'll pull up Maitland's grading criteria for mobilization and give some indication as to why. So what I'm getting at is, even though the types of distraction, meaning static, intermittent, or cycling, it seems as though there's only three, but really there's a multitude, many combinations as to why you would potentially choose one over the other. But you must also consider the other components, which is the duration of the hold patterns in intermittent, even the duration of the hold pattern in static, but the speed of the transition, as well as the overall amount of force that you're actually using. So in essence, when we think about why choose one pattern over the other, it goes back again to the same reason of why you may be using a specific term in mobilization, and now we're just able to use it from a mechanical standpoint. So I think it's also important that when we consider the type, that again we go back to the dosing, and typically what I tell people is it's not based on the feeling of the patient. You really need to have an understanding of your device and apply the same logic as to why you would use a certain degree of force, the amount of resistance, when applying mechanical distraction. It's based on what your desired outcome is going to be. Obviously, we use the patient response to that, especially when we're looking for the upper limits. But we as clinicians would certainly have a better understanding of the lower limits, or how much force and what it actually takes to get the desired effect that we might be looking for. Because in the spine, especially in the lumbar spine, patients do not have really good two-point discrimination, graphesthesia and stereesthesia. In other words, they just don't have a good sense of what's going on in the lumbar spine. So we don't want to use them in terms of telling us exactly what the degree of pulling is. And depending on your device, if you used a recent device with technology that multiple phases in the progression phase result in accommodation, and even your holding patterns may result in accommodation, and therefore the patients don't have a good sense, and you can over-treat a patient in one treatment. So looking at Maitland's joint mobilization grading scale. So we've got 5 different levels to Maitland, and Kaltenborn's very, very similar. And there are reasons we use a grade 1 all the way up through a grade 5. So it includes the indication of whether or not you want to necessarily use something static or intermittent, or something of a cyclical nature. But so we can use this as a pretty good guideline to assist us in determining what should we choose. And I'll cover a little bit more here in a second. But essentially, the higher the grade, the more, I don't want to say invasive, but either more force, more speed, and or more duration with regards to the length of time that you're going to be pulling any said amount of force. So typically grades 1 and 2, those are your lowers. You may use those during the acute stage of an injury as an initial amount of mobilization technique into an articulation to also test and determine the outcome following your procedures. And then, many of us, we may perform a thrust maneuver on a joint articulation, and then follow that up almost immediately with a grade 1 or a grade 2, which has been shown to reduce the potential side effects, such as a spasm or hypertonicity. So then when we look at the higher grades, So the grades 3 and the grade 4 were really looking to increase the amount of intensity as well as potentially the duration to influence the amount of mobility that's going to be going on in a certain articulation. And then a grade 5 is your thrust maneuvers, your adjustments, chiropractic, osteopathic, whatever you want to call it, where it's very, very rapid. It's at end range and uses a high degree of velocity, and it's usually a little bit more technical. So that one's not even replicated by our traction devices. At best, you're probably able to accomplish a grade 1, 2, 3, maybe even a grade 4 if you have the right device. And so, again, looking at what are the potential indications for mobilization, I think Maitland's outlined this, as well as Syriac's, especially in looking at the reasons for why we would use these. I also put within your grade 1 a static. So if you look at why we've used static historically, because it does certain things that may be indicated, and it's ironic that it actually meets it at two ends of the spectrum, either the really early phase of a problem or a very late phase during a chronic condition. So what I'd like to do is sort of use some indications or use a guideline as to some of the protocols. But these are the potential outcomes for the types of mechanical distraction. I sometimes put indications, but I like to say outcomes, because then you can sort of decide, because there's no set, here's the protocol for, a specific diagnosis. We don't really do that as much anymore. It's more so about what's your disability. You find the disability, and then you use and that's kind of your indication. And then you use your desired outcomes toolbox to determine what it is that you're going to be applying to the patient to manage their condition. So we look at static. Static's really good at tissue extensibility, because that sustained stress-strain relationship can result in plastic deformation to tissue. Suppressing muscle activity works really, really well at decreasing muscle tone by reducing motor neuron excitability. So if in fact you have hypertonicity or spasm, we did some cool stuff. I think it's cool looking at the influence, neurologically, at even creating symmetry between the right and left sides, not only of the paraspinals, but also the extremities. It can reverse a disc protrusion or a herniation, because it creates negative intradiscal pressure. Intermittent mobilization, right? So that's the greatest reason. You have two different levels of intensity that result in a gradient, and that causes mobility if you're using the right device. And so, if you have someone who's hypomobile, then this works really, really well, because it creates mobility and all the factors associated with that. So if you have need for improving mobility because of degeneration, because there's edema in the area and you want to influence the lymphatic return, or I love using it for mobilization of the neural tissue, which is a great opportunity to do things otherwise that might be rather difficult to do. Same thing, reversal of a disc protrusion, especially when you're using a gradient where it's only about 30%. So in other words, you have your higher intensity at whatever it is that you decide, and then your lower intensity set at 70% of that. That way you don't reduce all the way back down to a zero intensity, so that you're not letting it go all the way, so to speak. There is potential of tissue extensibility depending on how long you're going to hold it. Cycling, really, the focus on that is mobilization. There's no law, so cycling typically can occur at any duration, just like intermittent does. But again, we'd argue that why are you holding it at certain time frames? But again, that's there's no complete consistency. So this is some of it's going to be speculation. So I think there's two opportunities during the acute phase. So think about the goals of your approach, and when someone has an acute injury, so we want to decrease further injury, decrease further edema, and we want pain reduction. So my expected outcomes is immobilization, decrease in spasm, and mechanoreceptor stimulation. from this particular type of approach using mechanical distraction. So static works really, really well. And I think back to, being an EMT, and on the ambulance, we carry a hair traction splint, which is used to treat femur fractures. So we end up pulling on the foot. The other end of it goes beneath the ischial tuberosity, and we pull tension, and it's held statically. It reduces muscle spasm especially the hamstring muscle. So it's not designed to pull at really high intensities that would otherwise create mobility in an area that we wouldn't want to do so, because I think the misconception still is that mechanical distraction is used at really, really high intensities. So this could be used as subacute or even acute, again, if you go back and look at the criteria set forth by Maitland. So decrease edema, tissue proliferation, pain. I actually use a 5-second hold pattern. So it's intermittent, and it's 5 seconds at the higher intensity, 5 seconds at the lower intensity. So again, you're creating just a little bit of mobility in there, but you also have to take into consideration the intensity. So I don't use a high intensity because that would obviously create more mobilization and provide more tissue tension that may be contraindicated, during a certain phase of treatment. Your classic disc herniation, especially with radiculopathy, our goal is to create nuclear migration and to reduce pain. So the classic approach to decompression therapy is using intermittent, a higher intensity and a lower intensity. So it creates negative intradiscal pressure, and if it is compressing on a nerve root, you actually can result in nuclear retraction. So again, that's where we see intermittent. Same thing, multiple levels. Ironically, you look at the literature, and a lot of people have comorbidities, and that's why you see some similarities, and again, why intermittent traction works really, really well, because a lot of these people they're pretty stagnant. They're not moving around a whole lot. So this is a great way to get motion into those particular areas. So this is a later phase. So imagine going through a course of treatment for someone who has multiple levels of degeneration. And now you've created some mobility in there. Now you want to maybe enhance some of the things that you're doing with, say, a McKenzie protocol and influence the tissue extensibility. So static works really well. I said earlier, static, ironically, it meets at two ends of the spectrum to where it can reduce muscle spasm or hypertonicity during the acute stage of an injury, all the way up to create tissue extensibility during the later phases. So that's a great opportunity to create tissue extensibility, and then potentially, if you're working on a McKenzie protocol or restoration of a curvature, or at least trying to reintroduce a lordotic curve, say, into the cervical spine or the lumbar spine, we've actually found this to be a really comfortable approach and enhancing the possibilities of creating that opportunity when the patient completes their spinal distraction prior to do their extension types of exercises. And then, either a non-spinal injury or mobilization or whatever the case may be, doing some sort of cyclical or a rapid intermittent. I'll show you an example of cyclical here in a second. But again, just creating motion. And the nice thing with some of today's devices, you can actually set this to a really short hold pattern, and it allows you to create a lot of oscillations, a lot of repetitions within a period of time. And of course, we are really referencing the DTS device here. So the DTS has 5 embedded pull patterns in it. So this is your classic disc decompression, to where it's an intermittent cycle. And so you can set the duration. Usually the duration is going to be somewhere between 30 and 90 seconds, with the midpoint being 60 seconds. So you hold a higher intensity at 60 seconds, and a lower intensity also between 30 and 60 seconds is very typical. That allows you to create a fair bit of force. So the nice thing about intermittent is it allows us to use higher distraction forces more comfortably, because you're not holding it as long, right? That stress-strain relationship, that if you hold a very high force sustained, you can create an inflammatory response. And that may not be something that you really want to do. You may want tissue extensibility, but you don't want to result in what would cause traction hangover. So this is your classic disc decompression type of protocol that we saw coming out of a lot of devices in the 90s. Oops, let me fix that. And so additional increase in the upper intensity. So this is, it's an intermittent, but it kind of has a bit of a cyclical nature to it. So what this one does is it holds for a period of time. So the benefit of doing this is you get to an endpoint, so to speak. Then you may get some result in tissue extensibility and a reduction in muscle tone potential if there's any fibrotic tissue in the area. So this additive gives you additional mobilization at end range, which is kind of interesting. That it's otherwise would take more time, if you were doing this by hand, and it requires a little bit more force, but also the endurance for you to hold a pattern and then add more resistance after 30 seconds, for example. And this is the opposite effect. You're holding, this is a step down effect, so you're holding at higher intensity. This also could be used for chronic people that maybe you don't want to hold for extended periods of time, but have basically two lower phases that will allow for some additional mobilization into the area. So the DTS4 pull pattern, this is very cyclical. So it's just a progressive increase in the intensity. So it really goes through like grades 1, 2, and 3. If you're looking at Kaltenborn's grading criteria for spinal distraction. But the nice thing is it's progressive, and then it has a rest phase to it. So it's not overly aggressive like a sustained high intensity traction might be, or a high intensity intermittent traction. Works really, really well in older adult patients, especially in the cervical spine. Their number one cause of neck pain is radiculopathy and myelopathy, and so multiple levels of degeneration. So what this does, if you think progressively of getting from the upper vertebrae down to the lower vertebrae by increasing the level of intensity progressively, it's a really nice mobilization in the full spine area of the cervical or the lumbar, and it tends to be relatively comfortable, and people don't tend to experience a lot of side effect or soreness from that. This is similar to what I'd shown before. Is this, and being able to change the hold pattern. So this is a zero hold pattern, so it goes up to the high intensity. As soon as it reaches, it goes down. And because we can change the speed at which it transitions, you really can kind of mimic, some of these mobilizations that we might be doing in the extremities, but now be able to do that with the spine. And again, we don't have all the answers as far as the indications. I mean, some of the opportunities out there are, again, they're basically, we try and match them up with the reasons that we do it in the extremities. And so I think it's pretty intuitive. And right now, that's our best answer, because we don't really have a lot of comparative studies between static and intermittent spinal distraction. So that's, I think I'm on par with the others as far as indications, but whether it's indications or not, using the outcomes, I think it can be pretty intuitive as to why you may choose to do what you need to do. Hope that's helpful, and we'll see you next time.